Chairman, it's a pleasure to be here with y'all today to discuss Medicaid's appropriation. Look, we've got a balanced state support budget for state fiscal year 22. State fiscal year 2022 will be the fourth consecutive year without a state funding deficit. For those of you that took office after 2019, this balanced budget may seem commonplace, but for the decade before, it was always an annual source of discussion. The vision anticipates a $500 million carry forward of state funds at the end of 2022. Now, because the Biden administration has kept the public health emergency in place, we will need additional federal spending authority to close out the state fiscal year 2022. Given the continued uncertain end date and the potential for federal spending that federal spending authority could be an issue both this fiscal year and next fiscal year, we are asking for legislation that would allow the division, under very limited circumstances when the FMAP changes, to escalate federal funds. We are currently requesting $899 million in direct state support for state fiscal year 2023. That number could be adjusted during the session as we get more insight into the public health emergency timetables, federal legislation, pending CMS reviews, and state legislation. We expect any year-over-year carry forwards to be exhausted by state fiscal year 2025. And it is important to note that by state fiscal year 2025, the division would need up to an additional $300 million in annual state support funding. From an operational—
What's that for? I'm sorry.
That's for additional funding for the Medicaid program, increased medical expenditures over time, and the reduced FMAP. And also, we have been using these carry forwards year over year. And once that runs out, you'll be faced with we'll have zero cash balance. So it'll be a full appropriation.
When do you see the FMAP changing?
We have made predictions and we've been wrong every time. Friday, the Biden administration extended the public health emergency again. It could go up to the middle of April. We are right now we're forecasting a June 30th, 2022 end date. But I have serious questions about whether the Biden administration would actively end the public health emergency. And I think more likely it's going to require, Congress to take some type of action. The Build Back Better legislation did contemplate an end date in the spring of 2022 and put some parameters in place that are not currently there, like a step down on the FMAP where the states would continue to get enhanced FMAP for a short period of time while they went through the redetermination process, and provided some additional requirements on states as they unwound the public health emergency on different contacts that needed to be made with members before you could make the full eligibility determination, something that might be a little more robust than what we've traditionally seen. So we have continued. We thought the end of 2021 would be we would see the Omicron comes. There's still chatter, and when the administration has talked, some about universal coverage, and seems to be really focused on numbers, both in the Medicaid and marketplace population. Have a tough time seeing them actively deciding to say, "Hey, this emergency is over, and let's go back to let's move forward." We do have some good news on the operational front. The federal payment error measurement rate audit process that's intended to measure and report an unbiased national improper payment rate for state Medicaid programs. That data came out late last year. State-specific data publicly released for the first time showed that Mississippi Division of Medicaid has one of the lowest payment error measurement rates in the country. We were the fourth lowest among the 34 states with publicly available results, nearly 3 times below the national average. And Mississippi Medicaid had the third lowest eligibility error rate in the country, nearly 7 times below the national average. These results show room for improvement, but they also demonstrate that Mississippi Medicaid is comparing quite favorably to peer states, and our ongoing efforts to be fundamentally sound and fiscally responsible and committed to compliance are bearing results. One of the legitimate issues raised in provider hearings in 2020 was the lack of responsiveness by the division on state fair hearings related to the Mississippi CAN program. We went to work to address this shortcoming, and this year there's been a 19-fold increase in the number of managed care fair hearings conducted. The backlog that had existed since 2017 is essentially gone. And the only appeals remaining, for the most part, have not been held yet at the request of the provider. There should be nobody waiting on their hearings that hasn't been contacted by the Office of Appeals to discuss the appeal and to schedule a hearing. We've made it a priority to ensure that we communicate quickly and effectively. And we've also revised the hearing procedures and policies and communicated those changes to all 3 managed care organizations. We've got.
I'm sorry, let me just ask you on those appeals, how many were found in favor, percentage-wise, found in favor of the provider?
It has been back and forth. I will have to get you the exact number that the hearing officer recommendations come to me, and it's trading punches is probably not the best way to describe it, but it's back and forth. But yet we had expected that we would have some bellwether cases, and we would start to see a pattern emerge. And one in some of these larger, where somebody had a lot of these appeals, but what we're seeing is it tends to be a back and forth. I think the managed care organizations may we may affirm their position more than the provider side, but it's not overwhelming. Medical Care Advisory Committee is back full steam. Dr. David Reeves, pediatrician from Long Beach, is chairing. They have been examining policy on observation stays. They've submitted a couple of recommendations via letter to legislative leadership. One was to asking to consider addressing legislative rate freeze during the session. The second was to consider support or and further study of these certified community behavioral health clinics that basically are a cost-based reimbursement model for community mental health centers that offer some additional services and are able to meet certain quality metrics. That is something that the coordinator of mental health accessibility has been looking into. We've heard from his team as well as the Department of Mental Health, and I think conceptually it certainly seems like something that may be worth exploring further. Success is often determined in the details and the execution, but as we look at different ways to pay for healthcare services and our behavioral health is an increasingly important part of our delivery system. I think that's something that probably warrants further discussion. Consolidated credentialing continues to move forward. We are in the final stages of our Medicaid management information system replacement. And as part of that, we will be moving to a more streamlined process for the credentialing and qualification determination of providers. Now, I think the new system will improve operational efficiency over the long term. It will improve the provider experience. There will be some, like any big transition of a system like this, there will be some growing pains, but I do think over the long term we will see benefits. The agency, and I think Medicaid agencies across the country are facing some stiff headwinds. And most of which I think relate to the federal public health emergency and coming out of the federal public health emergency. I know some of you are familiar with, Congress did pass legislation giving Medicaid agencies additional federal Medicaid funding as long as those states kept everyone on Medicaid for the duration of the public health emergency. So each state receives an additional 6.2% federal match for medical expenditures. The current medical match in Mississippi is 84.51%. And this increased federal match expires at the end of the quarter in which the public health emergency ends. What does that mean? Well, we have seen an increase of, I believe it was 16.7% in Medicaid and CHIP enrollment since the beginning of the pandemic. So by January 2022, an additional 119,000 Mississippians had been enrolled in the program. There have been some short-term benefits. State budget pressures have been alleviated. There have been some additional flexibilities that are available. Hospital provider assessments are lower, but like a lot of temporary federal enticements, turbulence tends to follow, and the longer it takes, the harder it becomes to unwind. And we're now, approaching the 2-year mark in this, public health emergency state. I think that's important to discuss because I think a few things are going to happen. Number one, the federal match is going to go down, but the enrollment is not going to immediately go down. Now, recognizing some of the logistical challenges of doing a new redetermination for nearly 830,000 and probably more by that point, CMS is going to give states 12 months to come into compliance. And we are going to try to get many of these determinations as quickly as possible and are developing plans that will, target the likely, ineligible first for redetermination so that, there's an easy headline in the making because you identify a bunch of people that should not have been on the rolls for a certain period of time but stay on longer. And there are some real, financial repercussions of that. And there's also, however, it's very important that you don't make mistakes and disenroll someone who qualifies for benefits because you're trying to get through this mountain of redeterminations with a workforce that's still learning the rules around the unwinding of the public health emergency. I think with the reduced enrollment, I think there'll probably be the reemergence of some issues that were, I think, percolating probably prior to the public health emergency. if these level of care decisions around or determinations for some of the disabled children living at home, some of that I think has been addressed on the agency side, but some of the hard decisions about disenrollment may have been postponed. Now that is a pretty small eligibility category. We're talking about several hundred that might potentially be affected, but you're looking here at probably close to 100,000 that we would see eventually disenroll from the program because they don't meet those conventional eligibility standards. Mississippi is going to be unique as we start to go through this because we do expect the MMI system to go live. This ordinarily when you're replacing a system and after operational go live, best practices to stabilize the system for a certain number of months, make sure there aren't bugs and you aren't adding different functionality to the system, because you do have to take it in front of CMS for approval to get some additional FMAP. With the public health emergency unwinding, there may be some coding changes that are required, and if it doesn't unwind, if there is not the end of the public health emergency, that presents a different set of challenges around this system replacement. I think as I look at the different stakeholders, and I think as we look to become more effective, and whether you're talking about Division of Medicaid employees themselves, providers, sister agencies that are part of the program, or vendors, I think it's imperative we look at it, the efficient allocation of taxpayer resources, and whether policies and procedures that are in effect need to be refined to advance flexibility, responsiveness, and value. We would ask that we continue to work with you and talk to you and ensure that the division's got flexibility to attract and retain a high quality workforce, and also adjust to changing conditions. I think the SEC Squared project, spearheaded by the personnel board, has the chance to be successful and good for the state as a whole, and would really commend them for a very large effort that was done in a reasonably short period of time, and for lawmakers and their willingness to work with them on that. Time will tell if this is a true effort to modernize the government workforce, or if we simply end up creating more competition amongst agencies for a dwindling pool of available resources. We were one of the agencies in 21 that saw salary and fringe go down. It went down by 5.2%. I think we've been building up a little bit since then, in large part because of the need for to have positions filled for redeterminations and through the public health emergency. Initial budget request for salary and fringe was just 400,000 a month over 21 actual spend, but we are going to be we've been looking at the working on some of the information that the Legislative Budget Office has provided, and we'll put out a really thorough analysis of what we think we need over this over the 2023 period. We've tended to try to get smaller, and I think you have to look at a lot of different factors, and sometimes that makes sense when there are unnecessary redundancies or skill sets that really aren't needed as much as they used to be. But we really do need to, I think, attract some different capabilities and really make a focus on ourselves, on upskilling, reskilling, and helping our workforce grow. I think the Medicaid agency as a whole, as an insurance payer, has to start acting, like, and, ensuring that we're, you know, focused on operational effectiveness and the type of things that make businesses, successful, customer responsiveness, and but also that we've outsourced pretty dramatically over the last 50 or 60 years to some very sophisticated functions with some very sophisticated vendors. And there's a large responsibility on the agency itself to have the tools to understand that performance is where it needs to be, and that we are getting value for what we're paying for, and that these services really are aligned with best practices. And this is not outsourcing is not turning over the keys and letting someone else bear all the responsibility and do all the work. There can't be unnecessary micromanagement, but there has to be some understanding of what's expected if we're going to do it that way. And that's probably over the next 5 to 10 years going to take a workforce that may get may be the same size, but the skill sets may be a little different. And what we're not looking for is more, did they check all the boxes? But our taxpayers and beneficiaries and the people that we're serving, are they getting value for what's being provided? And are we continuing to make sure that what we're asking for is the right thing? Look, our support agencies also deserve a lot of consideration, and I know Chris Howard will be speaking to you later, and he may have some thoughts on reimbursement for some of the folks that serve the independent living waiver and the traumatic brain injury spinal cord injury waiver, and may have some really good thoughts. And Medicaid's not just the division; it's the Department of Mental Health administers waivers. We're supported by the Attorney General's office, and a lot of our procurements are the Public Procurement Review Board over at DFA, and the ITS staff and ITS board are very involved in the procurement process. And I think one of the challenges for the Medicaid program is sometimes moving forward with through some of the red tape that is there. And what we want to do is make sure that ITS has some of the resources they need if that's the direction that we need to go in. We need to be supportive of them with an analyst that's focused on Medicaid projects. Then I don't think that would be a bad use of resources. And so I think we're certainly considering different options and approaches there, but we are going to, I think we are spending probably the pace at which procurements are taking in state government is causing, it has a real cost to the public, both in terms of what you're paying for, and also your ability to pivot and move forward. If there's there are different ways to promote growth, but if your vendor knows that you can't get rid of them because it takes over a year to replace them, or the systems themselves can't be managed but by a few people, it's really you've really lost control of the relationship. And I think we have to think about some of the impacts around. I think where we really would like to start looking at, and it may make more sense on a pilot, some piloting early on, but take look at a private, follow some private sector approaches with, put the specs together, have a competitive process. We all want competition, but take it out of some of the layers that don't, that may not exist in the private sector. And yeah, if we can get the turnaround times down, and there's good conversation back and forth that lawmakers, that you're actually in support of this, that in support of moving forward with some kind of adjustment or new system integration, whatever it is. We need to do it faster, because we find ourselves having the same conversations today that we had years ago, and the federal government puts time periods on how quickly money needs to get spent, and then we start to look and wonder why there's so many emergency contracts out there. And there's some sometimes and I think we need to continue, and I think it's worth it's something that we have to think about ourselves, is how quickly are we moving. We need to do a better job navigating through the bureaucratic processes, or is it us, or do the processes maybe need to get adjusted a little bit, that really don't add a lot of value, that just slow things down without safeguarding. You got to have reasonable safeguards from taxpayer funded agencies, but that thinking through it from that perspective of overall value. You've run a business here in Blackwell, and I think your perspectives on that will be pretty useful to the Medicaid agencies going forward. That also brings provider reimbursement. People may have felt like we were never interested in that, but that's not the case. And I think we have to really look at, think that's not, provider reimbursement is 97% of Medicaid expenditure. So, it needs to be thought through, obviously, and make sure that you're getting, good value, and that to the extent and at the times that we do have, discretion in, rate setting and pricing, that, we're doing that thoughtfully, and that we can have responsible discussions about it. I think there's a lot of misinformation that exists about provider reimbursements. I've heard the latest that the division's frozen outpatient hospital rates since 2012. That's outpatient hospital rates have been benchmarked to Medicare for the last 10 years, and it's gone up. If you look at a level 3 emergency room code, a 99283, probably the most common outpatient hospital code, that's gone up 55% since between I think state FY13 and state FY21. Inpatient hospital, the per discharge amount it's gone up over the last 6 years. Now the volume's gone down, so that creates issues, but it's those kind of things that we can't just have this, Medicaid's not increasing rates, for the legislature's not increasing rates. There's a lot that goes into all of this, and we need to be able to have that good, with reliable information, and have that good back and forth, so you're informed, where there are decisions that need to be made, and and where we can feel like we're adjusting the market conditions and are really in line with what's happening, both on the commercial side and in other states.
Let me kind of stop you right here so we can get everybody else in, but I'm sure we'll probably see you back at a committee hearing sometime this session, and you can elaborate more, but just have a couple of questions on your travel expenses. It jumped up significantly. What was going on there?
We stopped traveling during the public health emergency, and a lot of those, as the our case mix nurses that go out to some of the long-term care facilities to look at acuity, and some of our other financial and performance auditors, some some of those things were converted to, virtual. My understanding is some of that, some of the flexibility that CMS may have given there, no longer exists. And I think if you look at where we're budgeting compared to what we've spent historically, that's still probably significantly lower than, what we saw over, in the, in years past. There's that elbow. Your out-of-state travel shows up in the elbow report, and you don't want to see somebody with 7 trips to different places. And we recognize that sometimes there's some continuous education and some training that maybe that people need to go to in person. But I think probably we're going to start to see going forward that these travel costs are not as large as maybe they were pre-pandemic.
So you're basically saying if I were to go back and look at pre-pandemic numbers, we'll be in the ballpark?
I believe so. And if I'm telling you wrong, I'll go back. We'll go back and check it and make sure. Take the FY20 and see where we were in 17 or 18. But it had been on a downward. It's been on a downward trajectory for a couple of years prior to the pandemic, and then it really decelerated.
All right, how about your contractual? Because they jumped up significantly also.
Contractual, we're finishing the MMIS, the system replacement right now. So, we're incurring the cost of the legacy vendors, and also the cost of the what we call the DDI, the design, development, implementation, the new vendor. We're expecting to see some, that number decrease as these vendors go live. There will be some. I think I don't know where. I think that's. And also with, I think the actual figure from 21. Do we end up with that? We rarely end up maybe with some of those contractual figures end up being a little lower because we tend to end up going slower than we sometimes than we think we may be ready to go award a contract and start moving forward, and we're still in the solicitation process. So sometimes some of the project list gets delayed, and that ends up impacting some of those numbers.
Any questions from the committee? Senator?
Real quick. So I've heard a lot, or not a lot, but I've heard from a number of people about the legislative freeze. Can you tell me what that's doing and what people are, where that, and I will tell you, they complained to me about it.
Right. Well, I think the language says that no payments or rates should be increased, decreased, or otherwise changed without amendment to the section, by the legislature.
And that was put in the bill from last year.
That's right. And I think it was some legacy language, but some of the legacy language, there was another paragraph that didn't get put in that may have given us, I think would have made, perhaps given us enough. There'd been enough ambiguity to say, well, let's just keep going with these state plan methodologies and just follow the payment methods that were in place, not the payments or rates. But I think we've had 36 state plan amendments approved to stay in compliance with the freeze language. Pharmacies still being reviewed. Those historically have fluctuated, and CMS has some views on the currentness of those types of rates. So look, I think in 2018, when there was similar language, we were able to, legislature took that out. I think, there was some good, I think there was some good financial. I think the program was able to run pretty smoothly. That way there were some increases. There were also probably some adjustments that were made that, that had a downward, downward impact. But I think for cost base, for a lot of providers that are cost based, your long-term care facilities, and some of the others that's creates unique pressures. And for us, look, I think legislature makes the laws, and what if legislature wants to, it's rate setting authority can that can be as much as legislature wants it to be, or as little. You see states taking different approaches. Where we want to stress where we don't ever want to be in a situation where a following state law comes into conflict with pulling down federal financial participation and being able to get the match money. So I think some adjustments that could I think it would be good to give to allow us to allow providers to be in a position where there can be some adjustments as market forces change and
Okay.
that type of thing.
Then just comment. I will say you opened your presentation by saying those who weren't here since 2000 or who've only been here since 2019. I agree. And the 4 years of flat state support is a big change, and that's a credit. I hope people recognize that. That's a credit to your leadership and Governor Reeves's leadership. I think people need to understand that. And it does make as an appropriations member, it makes the setting the budget much better. I know there's different things, but just looking at this chart right here, that says something. And I'll be interested if the press actually writes something about that, because I don't normally see that they've written anything about that. So thank you.
Senator McLendon.
Yes, I don't feel. What about the last 12 months? Such an escalation. COVID, all COVID related.
I think very little of it is COVID related. I think it's driven by the fact that because of the public health emergency, we're not allowed to disenroll anyone that was eligible March 18th, 2020. It became eligible after that. So what you're seeing is, you can age out of the Medicaid program. Well, nobody's aging out right now. So, and right now, pregnant women have coverage up to 60 days after the birth. Well, that's indefinite. A lot of people start to earn more than they would normally qualify. They're staying on the rolls, and there's this what's called churn, is where people don't fill out their paperwork, and they may be healthy and they drop off the rolls for a month or two and then come back on, and that sometimes causes enrollment to drop a little bit. But when you're not seeing any of that, that's a large reason that you're seeing that in enrollment rate. It's starting to slow down if you run out of people that can actually enroll, but we're still expecting to see the enrollment go up slowly until the end of the public health emergency.
Thank you, Drew. Appreciate it. We have Child Protective Services up next.
You see the numbers. Hey, thanks, Drew.
CPS?
Mr. Chairman, you gotta make sure, some of them get searched.
Right here. Search me. How are you?
How are you?
Chairman Wiggins.
Hey.
My Commissioner Andrew Sanders.
Hey, Andrew.
Hi, how are you?
You got a good person.
I'm Shannon Warnock.
Yes.
Nice to meet
You
you.
got a good
The way it
person.
is for us.
Oh, have you?
Okay.
Oh, hush, don't
He's-
tell.
Oh, we're going out to eat.
We graduated high school together.
We're gonna get some stores.
We changed it to one,
You are?
but then
You
you
are
have
gonna
another
get
code
some.
section
You don't
showing
want-
it's still the old one. So you got two, you got one saying.
It's still a little funky out, but I'm hanging.
The
So,
more recent change
Let me make
should
sure
take
everybody has one.
precedent over those. So if you don't do anything, it should still be okay.
Yeah.
But we need to get it cleaned out.
Yeah.
But anyway, don't worry about it. So he's just gonna table it and move forward,
All right.
which takes all the heat off.
Sounds good.
Okay,
Thank
sure. You don't need another copy. Okay.
Hey, Andrew. Good, how are you? You go ahead and start when you're ready.
I know it's not on the slide today. Thank you for seeing us. I'm Andrea Sanders with the Mississippi Department of Child Protection Services. And basically, I just want to outline in a very brief period of time that we do have a request over LDR and the reasons for that request. Primarily, in this agency, our biggest expenses are going to be based on cost of living. We're very subject to changes in cost of living and inflation because we're taking care of children and their livelihood. We're meeting their needs. And additionally, the other big expense for this agency is personnel. I would venture to say that Mississippi has not yet funded the personnel needs of the agency, and this is an opportunity that we have right now to do that. I can tell you that I believe that I have a plan that we will never fix child welfare. People kill themselves trying to do it, but I think that we can radically change the system in Mississippi. I think it's going to take two things. It's going to take time, and it's going to take money. Time, I have negotiated a very small window of a 17-year-old lawsuit. The rebuilding period we are currently in, and it reduces 177 metrics that the state of Mississippi agreed to comply with. Something that is impossible to do, but I've reduced them to 4 basic metrics over the course of this year to buy us time to shift how we deliver care. I will be glad to sit down with any or all of you and tell you my bigger plan for how we're going to shift care. It's certainly not something we can do in 15 minutes today.
I'll be having you back later this session.
Okay.
And I'd like you and I to do that too.
I would be glad to do that. And so the big focus right now is we have to get the number of people where the children are, where we need them. And we have to get well-equipped, trained experts with those children. The work that we do is not the same as any other agency in Mississippi. We are custodians for nearly 4,000 children 24/7. We don't have beds to put in. We don't have placements. We have to negotiate that and contract for that. We are their parents. And they are the state of Mississippi's children, and any need that they have, we are on the hook. So their safety is our duty. And so I'm going to ask you to think a little bit differently about this agency than you do every other agency. I'm going to spare you the theatrics today, but I've got a list with me of 123 children who died from substantiated abuse and neglect in Mississippi over the last 5 years. I can tell you which ones were in your counties. And this will continue to happen. This is the nature of our work. It's what we do, but we have to be better at it. And
But just so we understand, period, not that abuser died in your care,
No, sir.
that
No, sir.
y'all had to
be
come
very
in
clear. No,
because they, in the care of a caretaker, that happened.
correct.
Okay.
And, I could bring you horrific pictures and show them to you to show you what these workers do. It is very unique when we're asking people right out of college to come in with a college degree and work for less than $15 an hour. And they can go to Hobby Lobby and work for $18.50 an hour. They don't have to work on Sunday. Going into situations that are akin to what law enforcement goes into. And so I'm gonna, today, I told you last year, I'm not gonna ask you for anything until I know what I need. But we've got a right size caseload. I have to get the ratios that Mississippi agreed to many years ago met at 75%, not 100%, not 90%, but 75% by next January. That means that we have to net, we have to net 120 caseworkers to get where the state needs to be.
So when you say net, you mean to hire an
Because I probably
additional?
have to hire about 250 to 300. We're losing folks at about a 30% rate right now. It's much worse in some of the counties where we have very high volume. Chairman Wiggins, Jackson County, DeSoto County, Hines County. We're sending kids out there to a losing battle right now. I need to give them a job they can win. I need to prepare them to do it. I need to pay them enough that I can get them. So that's the bulk of our ask.
But can I stop you right there?
Yes, sir.
How much of that, I understand where the payments are and I understand all that, but how much of it is training? Because what I've experienced is, I think you and I've talked about it, is the workers, I've experienced where they're giving legal advice or they're telling people what is and what isn't. They're not the lawyers, where they shut down the parents or whoever it is when it gets into the system. As I've said in Jackson County, and I don't know where the money is, but one of the best things is having somebody who navigated people through the system. But the bottom line is it comes back, in my opinion, to training. And what is your thoughts on that?
Absolutely. There's only many things that we have to address. Show you in our overall plan for changing the system. We aren't even beginning to meet the training needs. We're training early for 8 weeks because that's what the settlement agreement agreed to many years ago. That should be the start. We've got to repeat. We're going to specialize their workload. We're asking young workers to go out there and do a little bit of everything. And then that's being, depending on what their supervisor thought that meant some years ago, it's morphed into a variety of boundary issues. And it's very difficult to track. It's very difficult to train to. If we specialize them and put them in a role where they do investigations, I can train to that. I can track the kind of people that are good at investigations, and I can invest in making them really good at investigations and keep them longer. If I bring in, Sean Tindall and I talked about partnerships where we could enhance their training with the law enforcement academy. We're not trying to create policemen. We're trying to be social workers. But we're talking about going out and making very, very serious decisions about children's lives.
And I would
They gotta
add,
be good.
huh,
They gotta be good at it.
yeah, and I think also that gets overlooked is these cases are handled in the youth court system generally, which is an adversarial system by the nature of it. Attorneys are used to that. My impression is, except for your really experienced ones, they don't understand the dynamics of an adversarial system and what that entails. And so that leads to those boundaries or those walls being put up. I don't know. That's what I mean by training too, is, look, we could sit here all day, but I think that that's a part of this whole scenario.
I think, if I last long enough, Chairman Wiggins, I mean, from stamina, quite frankly, life cycle of a commissioner is short. And I'm seeing why. But that's where we have to head with the system. We have to define throughout the entire legal process. I've had somebody start working on, my lawyer pay a lot of money for the Olivia White case while they're on hold right now. I've asked them to put together a process map for what it looks like for a child and their family to walk through the legal system in Mississippi from the minute they interact with us until they move out to some sort of permanent family arrangement. It would start with. It is a disappointing system. We have multiple types of court sitting, and the case is prosecuted by a prosecutor that varies quite a bit from county to county. Then there's really no one but us in the case for a very long period of time until we get ready to go to PR. Not represented.
I'm sorry, Mr. Chairman. Would you agree that most of those cases, put it this way, the intentional abuse and neglect cases tend to be handled by the criminal system because it's an intentional and they've done that. What seems to be the case is that people that they either don't have the resources or they just don't know, or they don't have the, what I would call the life skills. And so then the child is neglected or abused, and it's not because they're out there wanting to hurt this, to intentionally hurt the child, but it's poverty and it's
Social determinants of health.
ooh, what's that word? Social determinants of health. Okay.
Alcohol, drugs,
All right.
mental health, and, you know, we all drive up down the interstate right now and see everybody's just about to stack. Child abuse is going up. We've been, you know, families have been picked up at home, kids are not in school. So all of those stressors add to that, but you're absolutely right. Preventing that on the front end, that's part of the plan I'd love to show you long term. I think it will ultimately save the state money. I think that shifting the entire organizational structure so that it delivers care in a way that makes sense, start to finish, and breaks these jobs down into something I can train to and create experts in is part of that overall plan. But to get started, the truth is this year, it's going to take me this year to get people. I need human beings that are well qualified, suited for this work. They're willing to learn. I'm not to train them. It's just going to take time to improve the system. We have been running at a severe shortage for a very prolonged period of time. A lot of which can be tied to the pandemic. I would say that certainly worsened that situation. And, when you're running at a shortage of workers like we have, and you go 3 or 4 months of shutdown hiring, everybody goes home during the pandemic, it has a tremendous long-term impact. I walked into the agency and nobody was in the state office, and that's after the start of the pandemic. So we had some work to do. A big part of one of the 1.2 million here I want to explain very quickly is under the settlement agreement of Olivia Wow, we have to increase our foster board payment rates. That's the amount of money we pay families to take care of children for the state. It has to map to increase to reflect the inflation rate every 2 years. This is the year that we have to give that increase. It will be approximately 1.2 million. Based on 4.7% rate that Dr. Miller gave us on January 12th. The rest of the money, hiring 100 additional social workers and 20 supervisors for those social workers. That was part of my ARPA ask because I don't think that when we shift the way we deliver care, I don't think that long term we will have to have that many workers. But right now we do, and I only have until January of next year to meet this metric. I believe that if I meet these 4 metrics by January of this next year, we're come pretty dang close. I think I will be in a good position to renegotiate a different path forward in the lawsuit, or to go to a judge and say, we're in a whole different place here. But what I inherited was, I don't think Mississippi was on very good footing at that point in time to litigate our way out of this case. I would just open this up for questions. It's a short period of time, and I want to be sure I answer your questions.
Well, we'll have you back at a special hearing sometime later this session. What are the social workers start off making now?
They were making roughly 31,000. We were looking to get into about 34. You're gonna ask me, y'all help me here.
35 more.
We'd like to get them to 35,000, and then that will be reflected in a career ladder that's built in to keep them in the system for longer. We're also looking to give them an incentive to get their license. They got nothing. I want to promote
So have you,
expertise and excellence.
so have you looked at if you increase that base rate, what you have to do to your other folks to keep them in line?
Yes, sir. This reflects all of that.
Okay.
The 9,727,000 would get all of our agency to market rate. It would allow us to incentivize having a license. We would be able to keep a career ladder in place to keep them working for us long enough to get this training even completed. And this is a little bit different figure. We did ask for some of this down here in the ARPA ask. Do it with our general fund. We can draw down federal dollars to match. If we do it with ARPA money, that's federal to start with, so we can't use that to match additional federal funding. One of the places that we have a lot of, I call it low hanging fruit, and I hope that I'm not being naive. You mentioned the legal system and getting children through the legal system diplomacy. One of the things that I've recently had a big realization about, I said I was going to not do a lot of theatrics, but I just want you to see this sign. This is, I went to adoption, like a big mass adoption in Hines County in December, and it's a big celebration. It was really, it's one of the only happy things that happens in our work, to be honest. But there was a kid, it's like a thing kids, families do apparently, and they hold up signs and they take a picture at the end that says how many days they were in foster care in Mississippi. This was in Hines County. Kid was in foster care for 9 years. In that family that was a good fit that wanted to adopt him and hung up in the technicalities of getting there somewhere. That shocked me and horrified me until 2 adoptions later, a child who'd been in our care 13 years came up. So there are children, there are roughly 1,000 children in state custody who can move on to permanency. They have a home, they have a family that wants them, and they're hung up in the legal system. We have intentionally started tracking that. I've asked the AG to think differently about our agency, the same way I'm asking you to. We are not, the traditional SAG setup is not enough for us. We need a mini law firm out there prosecuting TPRs all across.
I was just going to say, my guess is a significant part of that is the TPRs, where the parents don't want to terminate the parental rights, except they haven't had a relationship with that child in 14 years. And yet they want to come into court and say, I object to TPR. Oh, one day, judge, I'm going to have my child. And I'll be out of prison, or I'll be off drugs. I think that's a big part of it. Is that what you're alluding
Yes,
to?
sir. And, without getting into too much, the problem is created a long time ago, 14 years ago, by a different court, a different prosecutor, and a different worker. And the cure it can be that an order wasn't signed properly or a finding wasn't made on the record. And so you don't have due process to get the child, taking somebody's parental rights is serious business, and it should be hard to do. But what we found is that a lot of times, particularly in youth court cases, the order might be a paper order and filed somewhere in the courthouse or in some court records, but it's not in my kids. Or particular language that should be tracked, that could be very simply put in order. We got referees, people who are running their own law practice trying to do this work all across the state. So I'm not pointing fingers.
No, but I know we could talk about it all day, but that's an example that because it's not written in the order by the judge, then the CPS worker is not going to do it. When I, as a lawyer, look at it and go, it's self-explanatory, or that's what she meant when she wrote it. But it's all about CY. It ends up being about CYA, if you know what I mean.
There is that, but if you think about it, then the person who can cure that is definitely not the $31,000 a year social worker. It's
And
a
that's an
lawyer who
important
has to
point.
cure it.
Agreed. I think that's an important point.
So
Yes.
we built out an Office of General Counsel that right now is sort of tediously working through that. And I've asked the AG to really beef up their staff and separate how they treat us from DHS, that they really just focus on CPS work. And we've done that successfully. We now have 600 cases pending trial across the state. That's phenomenal. We know where the rest of the cases are. We know where the problems in the case are and what has to happen to cure them. And I have lawyers looking at it and finding, okay, so the language wasn't in the order, but there's this language in the transcript this will suffice. But it's not something a social worker can fix. And so we've been asking them, we keep punting everything back to them.
I'm personally glad to hear you say that because I think you're right.
What are they gonna do? They're not gonna fix it. You can't go, tell a judge that they have to cure a problem that was created 7 years before they were on the bench. So we're putting lawyers on the problem. That's the reason for the ARPA ask for the $4.4 million to increase funding for lawyers over the next 4 years and move these children to permanency, because it's the right thing to do. It is so much better for the children and families, and it takes 1,000 kids off of our caseload. So you can do the math on that. We won't need this many workers if we start moving children more efficiently to permanency. Unless we see a spike, we're always going to be at the mercy of referrals that come in investigations. But doing more preventive work on the front end, handling those a little bit differently. There's some best practices out there that Mississippi needs to embrace. Start finding relatives and people who are close to the child earlier. Coach, Sunday school teacher. A lot of times the problems can be mitigated with short-term intervention while the child stays right in their community and their school. That's not what's happening right now, but that's kind of long. Anything else I can tell you?
What's the source of your students? You going, they just fresh graduates from the university?
We're really intentionally recruiting from social work schools, but yeah, a lot of times fresh, for that pay, even if we get everything up to market rate, we're talking about a bachelor's level social work student. The one thing I really have going for me in this labor market is that this is niche work. And there are a lot of people who go to social work school or go into this type of work because that is what they put their wheels in motion to do. And then they get in our system and they get blown in the face by it. And, they get discouraged. But I think that it is work that a lot of people are extremely passionate about doing, and that's something we can use to our credit. One of the hallmarks of this generation that we're trying to recruit to is that they want to do meaningful work, and so I got a good product to sell.
Is there anything in their curriculum that might prepare them for this type of work?
Yes, sir.
With your agency?
We are working with the chairman at USM and multiple schools across the state. This is one of those things that's going to take time. So we're kind of rebuilding some systems that were previously there that have deteriorated. But yes, we can work with them to build in curriculum in their training that fits workers out further along in their pre-service training. That really lets them hit the ground running a lot sooner than someone who's coming in without a social work background. And also do intentional internships where we bring them into our agency, and they have to, all social work students have to do a certain amount of field work that's prescripted, and we qualify as a field placement. It's very hit or miss right now. If a social work school knows somebody at one of our counties that will take a student, that's how it happens. So we're going to flip that and create an intentional internship program and put, the conventional workforce development concepts that we all know and fund and support, need to put to work in our own agencies and grow our own workforce. That's what we're trying to do.
Any other questions? Sure, appreciate it.
I say that I need to sign.
Do you think we should
Thank you.
try to do one more?
No.
We paid for the one at Mass
Personal
County.
opinion.
Mass County.
We did.
Oh, yeah.
Why are we-
Yeah.
I need to let them know.
We're still rescheduling.
I think they're, that's,
Who's it? Human Services?
yeah, we're gonna need to schedule. So
Yeah, DHS.
I've got to talk to Sherman Ryan before we go.
You're the chairman.
And it's just not enough time.
Okay, so you can reschedule the other two?
Yes, ma'am.
Okay.
Yeah.
And I'll let them know.
Okay. No questions, right? We can have all the money, right?
No, but you're good. You're good.
She's great. And she's compassionate.
Drew was in here before.
I would love to get
Next time you come.
And the heart.
Yes,
reward that kind of work.
the fact that we want a whole study, that's what this up here is. So that's why I said I would let. Talk to you.
They also run off the rails.
And I would appreciate that resume.
But also.
She's getting
We
into.
blame it all on them. They're not saying. They're not. $30,000.
Yeah. All right, thank you.
So that's fine. But. Yes, thank you.
Y'all have a good Christmas, everybody.
Yeah.
Have a good
Be geared up. Be geared up.